So this is going to be about biomarkers in oncology clinical trials, and as all of you know who've worked in this field, is that with the introduction of new targeted agents that only work for specific biomarkers or patients who have specific biomarkers, the field has really changed, and new concepts have been developed for clinical trials design. And here in this session, you really learn about the latest developments in the field. And I'm very lucky and very honored that I have 4 very, very distinguished speakers from 3 different continents here today. And I have the pleasure to introduce them all. And I'll start with Dr. Mike LeBlanc. He's going to start off the session. He is member at the Fred Hutchinson Cancer Research Institute in Seattle, Washington. He also recently took over from Dr. Crowley as group statistician of SWOG. And he'll talk to us about directing subgroup modeling in phase 3 clinical trials. So, Mike, please.
So, just, and then forward. Well, I first wanted to thank the organizers for approving the session, Ansha for organizing the session, and it's especially nice for me because I know all of the speakers here over time. We've met and we're good friends, and I was trying to think of how we all got to know each other. It was probably because of SWOG, but then I realized it was actually John who brought all of the speakers across the continents together here as well. So I wanted to acknowledge that especially. So topic, subgroups in clinical trials. We're all familiar with them. And this talk is a little bit expository, but tries to sort of look at both the situation where we know what those subgroups are ahead of time versus finding those subgroups and the impact on trial design. As Ansha said, one of my roles is directing the SWOG Statistical Center, which is in Seattle, Washington. It's a statistical center for a national cooperative oncology group that conducts clinical trials in the United States and elsewhere. And it's at the Fred Hutchinson in Cancer Research and Biostatistics. Okay, outline, quick I guess I have to look at the microphones, otherwise my voice goes away. So I'm going to do an overview of why patient heterogeneity is important in terms of the design of trials. What?
You can see him here too, your
Oh,
slides.
okay, good. So I don't need to be facing the back, good. But I might want to face that way anyway. Designs that either look at this either in predefined ways, so in some situations we know what those subgroups are, or we really believe we know what those subgroups are, versus actually trying to learn. And what I'm going to try to do here is one of the things that John introduced me to many years ago was the idea of flexible regression modeling. And so try to bring some what we know in that setting to clinical trials, so the back and forth there. I'll look at some trial examples that I'll have stolen from SWOG statisticians both here in the audience and elsewhere, and I'll hopefully try to acknowledge them because I'll probably botch up their trial designs when I try to talk about them briefly. Then I'll veer into the implications of trying to learn. So in the same way as we try to learn prediction models, what are the implications of trying to learn trial designs on the fly in terms of our studies? And then end with some quick conclusions. And I'll try not to go too long since I know I'm the first. So how do we, so background, in terms of cancer clinical trials, how have we divided up our labor, our trials in the past? And it's typically been by sites of disease: breast cancer, lung cancer, GI, genitourinary, melanoma, lymphoma, etc. Different disease sites or different cancer types, and we might have done trials within different histologies within these groupings, or by whether it's limited stage, advanced stage, or recurrent disease. But here's a line that's been used over the last 20 years or so. Increasingly, we can measure genomic attributes and other measures of heterogeneity, and how does that influence what we do? Well, all these disease categories were supposed to go away. They're still there, but it clearly hasn't been moving that direction. And along with that, we've developed drugs that sort of introduce interactions. It's not like gene-environment interaction. We're trying to introduce patient subgroups which actually benefit from therapy. We've got new drugs there. And of course, we can measure, we can have a finer and finer microscope to go know what's going on. So historically, models have helped us, helped interpret treatment effects and understanding the natural history of the disease. But parallel to that, hope that models can help us in think about how the designs should move forward. So identification of subgroups, which might be useful in designing clinical trials. So this slide probably is limited, out of date, has everything else going on with it. Basically, the intent of it is to say we have lots of drugs now that we think target specific biological processes for which we think subsets of the patients perform better. For instance, HER2/neu, Herceptin, an early example. One that I was involved with way back was Gleevec, I'll say it that way, a tyrosine kinase enzyme. And so targeting subgroups of patients where treatments affect. Those are designed subgroup effect drugs, as opposed to there's other situations where there's lots of examples where individuals have constructed gene expression profiles or other genomic profiles for which they now find treatments perform better in one group or versus another. An example that's used often, and we're familiar with this walk, is Oncotype DX, and so clinical trials have been designed around that. So again, review. So how do we learn in clinical trials? So just a brief review. Phase 1 trials typically look at dose, side effects, some very early efficacy in some settings. Phase 2 trials are typically used to assess for sufficient promise for further testing, and probably a little bit more aggressively trying to find subgroups of disease which look more promising than other. Some examples include single-arm studies, two-stage studies really testing, and now an increasingly randomized phase 2s allowing somewhat comparative statements between the arms and looking for subgroups of effect. And then formal testing at the phase 3 level. And I highlighted modeling there because really that's going on. It's just depending on how formally it's going on in each one of those stages. Modeling, probably going to phase 1 as well, but in terms of efficacy modeling going on at phase 2, can we figure out what the phase 3 design is? Phase 3, can we redesign what the next study is? So I'll talk about those. Here's a slide I stole and partially botched up from Richard Simon at the NIH in the US. But the intent of it is to say that in addition to figuring out whether you're going to make a no-go or go decision with respect to the phase 3 study, phase 2 trials now are being used, either formally or informally, to try to direct that effort with respect to the phase 3 design. And so how should you be using that data? How formally should you be controlling, thinking about uncertainty in that setting? In the same way as we think about predictive modelings, it's not just about at the end making sure you have a test sample to validate it. It's making sure you don't over-interpret the data early on to go down a bad pathway. So that's the intent there. So again, further review. So what are the situations we're looking at? In the case where, think about a gene treatment interaction, and along the x-axis is some measure of some genetic attribute or some attribute on a continuous scale. I just wrote down the quantiles at the bottom there. And overall, there might be an overall average effect, sort of a no interaction effect, of which case you probably think, well, there's no sense looking for subgroups. And another situation, there might be where the treatment, the green and the blue lines, the effect of the treatment cross or are only exhibited in one area. So in some situation where treatment B is better, and the other situation, that may be actually where treatment A is better than treatment B. So what are one class of designs that target that, and I think the next speaker will get into, target that area? Suppose you could find a group of individuals who are marker positive, genetic positive, call that R+, and those which you don't expect to respond to therapy, call that R-. Anja, please point me the times every once in a while to make sure I don't go too long.
You're 10 minutes now.
Okay.
20 more.
Okay, excellent. And then you would only randomize in that group where you really think treatment's going to be effective. It's obvious. If you randomize to everyone, you lose efficiency in doing that thing. So there's a whole class of studies that we now activate in that setting. So here I just replaced those abstract quantities with an actual real study. This is a SWOG study looking at in metastatic colorectal cancer, looking at vemurafenib in BRAF mutant patients. And so that top line were those which we don't know whether they're BRAF mutant or not, and the bottom pathway is where we know they're BRAF mutant, and then we give the new targeted agent within that group. Again, the same advantages apply. If you really know that that's going to work, that's a great situation. You haven't needed to do any real estimation on the data to come up with those subgroups. You just test it there. I had to throw this slide in because suppose you had multiple targets, and this is a study this opened up a few weeks ago with SWOG and the National Cancer Institute of Canada, and it's saying what would happen if we not just didn't know one target, but we had multiple targeted agents, and this is squamous cell lung cancer. And there's sequencing going on up front, tissue samples flowing around, identifying which mutation is going on. So imagine that prior study actually having multiple sets of randomized phase 2, phase 3 studies. And so the boxes across this represent mutational groups. So think about those, a bunch of different R+1, R+2, R+3 from before, and then they're randomized to standard chemotherapy versus whatever the targeted agent is. And there's lots of complexity to the design, they're phase 2, phase 3s, but the idea is that in this setting, we hope, or we placed our bets in the fact we know those targeted agents are working in those subgroups. There may be off-target activity, we're buying into this design. And then the subgroup that doesn't have any matches are randomized accordingly. So this is apparently the wave of the future. We'll see how it works, but it's that just taking, we're targeting, we're going to do our examples in those designs. There's lots more to be said about that study. So to contrast that, what if you had a design where you're trying to learn more about what's going on? What I said is we hypothesize what's going on, we're going to target those groups, but if you're trying to learn, then you want to be broader. And so in this situation, you might use a stratified design for the subgroups R- and R+, where we think the treatment might work a little better in R+, but we're not sure, and then stratified to those two groups. The advantage of this is probably disadvantage is first. If in fact the therapy only works in R+, of course this is not patient use, good use of patient resources and other things, but on the plus side you can actually assess what's going on with the R+ and R-. It might be a cut point, or it might be other situations where you're trying to really see whether those groups are useful or not. And so here's another study, again, as the prior GI study was by a statistician at SWOG, Catherine Guthrie, which actually is looking at gastric cancer. It's randomized phase 2 using ERCC1, excision repair gene expression, but it's stratified based on ERCC1, based on a prior chosen cut point, based on prior clinical trials, prior phase 2 clinical trial data. And but the advantage of this design is there's still some uncertainty with respect not only to where the best cut point is, if one can find it, but also even the overall distribution of ERCC1. So that allows you to do that. And I had to throw this in, I know Bill Barlow's in the audience. Suppose you're in that mid-range where you actually know that the therapy is related to some gene expression score, some marker score, but you're still not sure exactly where that point is. You could do both, right? You can target. So this is a study that uses the Oncotype DS recurrence score. It randomizes below a threshold of 25, but even below that, you want to gain more knowledge going on. And if you have a big enough study that's well powered enough, like this one is, the bottom plot here really indicates hazard ratios associated with the two treatments and trying to figure out the point where it's efficacious or equivalent versus whether it's not helpful or not, chemotherapy. So going through the situations where you know the targets, multiple targets, the situation where you're just trying to learn more about a single marker, and this one where you're trying to really do both. So I wanted to suppose you're in the situation where you want to try to know what's going on. These, I think, are some important quantities to think about. It's obviously the eligibility factors, and I wrote out, I'll have them called R. It's the model of the For the treatment outcome model, I call it MR. Basically, think about it as the survival, if it's a survival study, the survival for those individuals within that group of individuals, and the fraction of patients. That's key to everything we do because, A, you have to be able to run a study, and you want to have it when it comes down to it, as broadly useful as possible. And so you can think of classes of models, and we've done these over the time, thinking from way back when, looking at tree models, single split models, to other work in coming up with regions. We understand the reality of the world is much smoother than we typically lay on in these subgroups, but if you're trying to do actions, some techniques to do this in multiple dimensions. So those are just some examples, extreme regression and logic regression we've worked on in the past. And they've typically been developed for typical simple regression setting, but in this setting you might want to look at for subgroup effects or interactions. These methods work really well, typically if you've only selected one or two things or you've come up with linear combination, smooth linear combination to begin with. They kind of fall apart in the treatment setting after that. So just a little bit more on this. So again, think about these three quantities. Rules to describe the subgroup of patients, think about that protocol, those are the eligibility criteria. A model for the treatment in that group, because that defines what the outcomes that you expect. The mass of the group, which is basically the number of patients. And this triple really describes the design properties of future models. There's been a lot of work recently, and many of you work on optimal treatment regimens. And this is a little bit different. The idea here is not necessarily to find the best model to give the best average overall output for all patients treated. Think about models where you're trying to optimize some design properties of the next trial. That's a little bit different. They're strongly related, but a little bit different. And so just to end up with an example that shows what some of the situations are when we try to do this modeling, I thought I'd take a look at this. And part of this came out from the fact that we're very good at thinking about in prediction models that we have a test sample, training sample, we make sure we don't over cross-validate. And a lot of the phase 2 analyses that come up with these groups tend to be a little bit more loosey-goosey. So the implications of what that means in terms of designing trials. And so going in, it's sort of rewarding to see the same properties hold, that if you're looking for subgroups, you have to control your variance, otherwise the overall properties of your design kind of fall apart later on. So, simple example, I looked at a case a while back, so some simulations here, looking at a model that includes, excuse me, prognostic factors, efficacy modifiers, and a glass of water. And the relationship is this equation given below, showing a varying effect model for the treatment effect. Just a picture showing treatment outcome for outcome with respect to treatment A, treatment B. Darker colors might be better outcome. So then just looking at just simple set of cut points along 10 divisions as you're moving along, trying to get a more rarefied group where you see the treatment effect the biggest. And of course, you can think of all such much more complicated situations than this. This is sort of a schematic of what can happen. Antje, how am I doing time?
12 more minutes.
Oh, I'm fine. Thank you. In terms of censored, this is censored survival time. So we just generated some data from exponential models. We did it kind of trying to think about what was happening. Randomized phase 2, current often standard for phase 2 designs, followed by a phase 3 design. And considered several analyses. We looked at the top two lines, just looking at just only, okay, I'll leave it there. Only looking at the phase 3 data. So taking an overall analysis, phase 3, pretend there's no phase 2 analysis, or actually doing, as some people have proposed, actually adaptively choosing what that subgroup should be on the phase 3 study, controlling for type 1 error, and then doing the study there. And we compared that to doing phase 2 learning. I was told he's to do a phase 2 before his phase 3. It's resources well spent. So try to do that in terms of the phase 2, selecting a one single subgroup and taking it on to a phase 3, or taking a phase 2, selecting a subgroup, but covering my bases and also doing an overall test as well. So So you can kind of think of the analyses as putting all your bets on the phase 3, but forgetting about any of that marker data. The second one, just using the data on the phase 3 as much as you can, but still controlling for the type 1 error at the end. And the next two is refining your hypotheses and going from there. And so these plots are not really intended to show too much. I show you here that, so this is results of the simulation study where I looked at the first plot varies the overall prognostic effect. The second three plots are interaction models, which are represented in the figure from the equation before as beta 3. And they influence the interaction effect, which of course turns into an overall treatment effect with the subgroup as well. So you think about main effects varying in all of these plots in different ways through interaction. And so the takeaway line is that blue line tends to be on top, which is in situations where there are subgroups, it might make sense, at least under this simulation, to look for them at the phase 2, but to cover your bases. That's the hybrid design, which said, if you're looking for a subgroup effect, refine your hypotheses, but maybe not refine it to just one subgroup because there's a power loss. And this is thinking about overall effect. This is thinking about sort of in terms of the overall sample size, not the subgroup sample size. In this setting, often the targeted group would be better if you did that. So again, back to thinking about prediction models, one of the things that people had problems with thinking cut points a long time ago, everybody says, oh, they're very uncertain. Well, here it has even had bigger implications. So this is a histogram of the subgroup selected by that simulation study. And 2 to 8 really represents the percentiles of the distribution. So it said, even though there's a subgroup effect here, it's not going to pick it in any particular spot. And so you could see with these varying subgroups. And so in other words, you could be in a situation where by chance you're picking a really small subgroup, putting all your resources into that subgroup where the efficacy is a bit larger. So the same thing that applies for trees applies here. You need to realize if you're doing this, or your clinical colleagues are doing this, of course, it's subject to that variation. And the other set of the story is also like prediction models is one of those functions I said you need to calibrate for future design is the effect size. Well, if you go through this very simple situation, which wasn't very adaptive at all, if you look at the survival curves, they're separated, and if you just did an average over one of the classes of models like that, the hazard rate optimism bias is probably a hazard ratio of about 1.3. So it would lead you to A, potentially too small a study, and a subgroup that's too small, and potentially designing it for an effect size is too big unless you calibrate appropriately. So the takeaway message is, going back maybe a few slides there, okay, be exploratory, but understand what you're doing with respect to variation. It's a old message and maybe an obvious one, but I think it applies here as well. So specific conclusions, I've said these already. If you were actually in a situation we could design a phase 2, a phase 3, you'd want to keep variance control. So in which case, control the type 1 error. Potentially not just send that one subgroup on to phase 3 if you think you're in a marker situation where you think there's some association that it moves more broadly through the patients, but rather send maybe 2 subgroups. But again, think about filtering those hypotheses so you only have a couple at the end of the phase 3, both for interpretation as well as how increased power. So in review, obvious statements. If you really know that there's really subgroups for which the treatment is designed to work, then build that into design. That applies for that lung master's protocol that I present, the squamous cell protocol. It also it corresponds to that breast cancer study responder, that was S1007. In those situations, there was a lot of knowledge about what's going on in those, and build those in. The critical factor is, of course, I think a critical factor, of course, is the fraction of individuals you're actually going to treat. And so keep track of that in the sense of, did you make a choice to go for a little bit smaller subgroup with a bigger effect, knowing full well it's too small of a target to actually work in a reasonable accrual period. As one of the experiences I've had in working in lymphomas is we've made mistakes sometimes of thinking, oh, our treatment really works in this very small subgroup, and then we can't actually finish a study in that subgroup. And then, of course, the last obvious statement for this slide, if you're going to adapt, know how you adapt in terms of knowing what the properties are going into the phase 3. Just because it's a new experiment doesn't mean you need to know what's going on to control your overall properties. So practical issues, last slide, second to last slide. Whereas modeling is needed and useful, given limited sample sizes, here's a typo, there may be sufficient information, but there may also be insufficient information to really move forward. Most talks end with, is there a better biomarker? If there's only a better biomarker, then we'd have all our answers to us. Here's some examples that are moving along in parallel. The ability to actually assess multiple drug combinations within a given tumor in vivo. And so there's technology going on in Seattle and other places to actually inject multiple drug combinations into a tumor while the patient's still there, excise the tumor, and then see whether that actually modulates effect differently. And you see what that gives you. In any of these high-dimensional situations, you don't have parallel assessments, and so this gives you matched data, and you could use that potentially to wait, but we have to wait and see how that works. There's also mouse xenograft models where you can grow up colonies and treat mice differently with that, with all their usual problems. So I want to end off with the acknowledgements. First, the SWOG trial statisticians that worked on these studies and designed these studies. Bill Barlow, S107, that was the breast cancer study. Catherine Guthrie with the 2 GI studies. Mary Redmond on the lung master protocol study. Ansha and John for being long-term colleagues in different aspects of clinical trials. So there was some nepotism in selecting some speakers here today. Charles Cooperberg, because I think understanding the mix of traditional, or I should say adaptive regression modeling, and thinking about trials design is useful, and we've worked on a lot of different methods for flexible regression and how that informs each other. And the SWOG clinical and translational investigators. As a SWOG statistician, I can't do anything without them. So thank you very much.
Whoops. It's a little difficult in this room with questions, but if anybody has something and can speak quite loudly. I don't see any takers. Oh, yeah. Yeah, go ahead.
Hi. Hi.
But, okay, so recently there are some interest in adaptive enrichment kind of strategy, right? Like Nora Simon, Simon and Simon, they have the adaptive enrichment study, and also Sujian Wang and others in the FDA, they also do that. So I think there's similar ideas, but my question is that when doing this, how do you can also do it sort of a discrete, like a 2-stage type of design,
right,
or continuous design.
Right.
For example, you can have adaptive randomization, even, kind of put more patient in the arms that showing more response condition on the covariates.
Right.
So what's your view in terms of, do you want to be more adaptive or less adaptive, or kind of a discrete stage or continuous?
Right. A lot of times discreteness works out easier just because of trying to get things through the system. Clearly there's situations where if you can get the outcome fast enough, you could do fancier things along those lines. You could adapt more quickly. I think a part of my conservatism in terms of this is not just my politics. It's also to do with the fact that I work in lymphomas, and a lot of times those endpoints don't come very quickly to adapt what's going on. In other situations, they're just difficult to pin down. So I think the variation, how adaptive you want to be and how you build up is an issue. With respect to phase 2, phase 3, the lung master protocol actually involved a phase 2, phase 3 look. And so there, because it was actually for registration later on, there was some push to try to do something in terms of adaptively selecting, say, cut points as well at the same time. But there was this pushback that frequentist or Bayesian, that was just a little bit too much on everybody, left everybody a little bit too anxious. So even though it's a phase 2, phase 3 design, we kind of fixed the subgroup ahead of time. But I do think there's situations where that's useful.
Sauer by Freiburg. I fully agree with this point, flexible regression modeling and so on. I may just come back to one of your slides in the middle of the talk where you showed 2 straight lines and spoke about the cut point, and they may, one treatment may be better on one side and the other on the other side. I think that's certainly something we need to do much, much more. But what you have assumed is that in principle you have assumed that the prognostic effect of this marker is a straight line for both treatments and both separate treatment groups. So jointly with Patrick Royce, I've developed an approach to look also for nonlinear functions. We also have some simulations studies showing that you can increase your power, and then to look for, let's say, in a fractional polynomial framework to get some better feeling as soon as there's some nonlinearity also in these effects, and then you can go on and work with it. And actually tomorrow I will present this approach also in the context of a meta-analysis, so you can do more with it. And I think altogether we really should use much more of the available data, and whenever it's continuous, we really have to do more with modeling and going away from all this terrible cut point stuff.
Right.
We need it later on for the decision
Right.
for designing new trials.
Right, no, that is a completely other strategy. You could, not completely, it's a variation on the strategy, which is you try to estimate those curves, as you were saying, and then see how, at the point of which they're far enough apart, to then use the cut points subsequent that to the phase 3, because ultimately you're probably going to need to act on a discrete space, ultimately for the phase 3 trial or part of that comparison. But I agree, there's advantages there. The difficulty is always is even if you're trying to figure out where the inverse regression, where that cut point is, you can do better than it's estimating cut points, but there's still uncertainty inverting that regression function at that point, but probably better efficiency.
Thank you, Mike. I have the great pleasure to introduce our next speaker, Dr. Shigeyuki Matsui. He is professor at the Department of Biostatistics in Nagoya University in Japan. And he's also visiting professor at the Department of Data Science in Tokyo. He will talk to us on all-comers phase 3 designs in the presence of biomarkers. So please.
Okay. Thank you, Angie. So thank you very much for organizing this great session. So the title of my talk is here. Okay. So my talk is also associated with biomarker-based clinical trials with some overlap with Mike's. But I more focus on design aspects, such as sample size and power calculation. So this is the background. So in recent years, so eminent advances in genomics and biotechnology have revolutionized drug development with a more shift to molecularly targeted agents. Compared with the conventional drugs, such a molecularly targeted agents are more prone to arise larger interpatient heterogeneity and responsiveness to drugs. So it depends on the status of the alternation or deregulation of the target in individual patients. In this revolution, the traditional methods for clinical trials are that are to evaluate the average treatment effects in a broad patient population are now facing with serious limitations, which is mainly associated with their inability in indicating drug responsiveness for individual patients at all. This limitation has been well recognized so far. This is from Sir Austin Hill, the pioneer in applying randomization to medical studies to evaluate streptomycin in treating tuberculosis. And So in recent days, so early 2000, about 60 years had passed over. So we can see now a new paradigm of clinical trials for personalized medicine. So again, the revolution in the genomics and biotech has also contributed to developing predictive markers as a tool for capturing the interpatient heterogeneity. And simultaneously, predictive biomarkers are being developed in drug development, that is co-development of treatment and diagnosis, and accordingly, clinical trials are becoming more complex. And when looking at a confirmatory stage, phase 3 trials are now required to establish clinical utility of the drug with aid of predictive biomarker that are analytically validated and hopefully clinically validated. As such, biomarker-based clinical trials will play a critical role in this new paradigm of clinical trials for personal medicine. Okay. For biomarker-based phase 3 clinical trial design, to establish clinical utility of a new treatment with aid of predictive biomarker, we can see mainly two approaches, as Mike already introduced. One is the enrichment design that to recruit eligible patients considered biomarker positive B+, who are likely responsive to the new treatment. This approach is generally most efficient when the biomarker has compelling biological evidence that a biomarker negative B- patients are not responsive. The other approach is all-comers or randomized all design that includes all patients are eligible for randomization as the traditional clinical trials, but we plan for prospective subgroup analysis based on biomarker with the control of type 1, study-wise type 1 error rate. This approach is generally reasonable when there are no strong credentials on the biomarker, which is more common. We'd like to focus all-comers design. So, okay. Many statistical analysis plans has been proposed for biomarker-based phase 3 all-comers trials. We shall categorize them into fixed sequence and fallback, and their hybrid, and treatment by biomarker interaction approaches. It is very important to note that all the approaches can demonstrate treatment efficacy for either the overall population or the biomarker positive subgroup based on the observed clinical trial data. Okay. I'd like to introduce each approach in order. So first, fixed sequence approaches would be suitable for situations where we can some biological evidence for which one is unlikely to expect the treatment to be effective in the biomarker negative patients, unless it is effective in the biomarker positive patient, that there are strong credentials on the biomarker. Okay. This is the first type of the approaches. We call it fixed sequence 1. So in this approach, for example, in a phase 3 trials, to compare a combination of chemotherapy, FOLFOX plus panitumumab with FOLFOX alone in metastatic colon cancer, we first test treatment efficacy in a biomarker positive subgroup using significant level 2.5% in one-sided. Okay. If this test is significant, we'll test treatment efficacy in a biomarker negative subgroup using the same significance level, 2.5%. If this test is significant, we may assert treatment efficacy for the overall population. Otherwise, we may assert treatment efficacy for the biomarker positive subgroup. If the first test is not significant, we may make no assertion on treatment efficacy. Okay. This is a second type of the approaches called fixed sequence 2, where at the second stage, we test the treatment efficacy for the overall population instead of the test for biomarker negative patients. Okay. The next fallback approaches to evaluate treatment efficacy overall and prepare a test for the biomarker positive subgroup as a fallback option. So for example, in a phase 3 trials to compare platinum-based chemotherapy and elrocim versus chemotherapy alone in non-progressive lung cancer, we first test treatment efficacy overall using a reduced significance level, for example, 1.5% in one-sided. If this test is significant, we measure treatment efficacy overall for the overall population. Otherwise, we test treatment efficacy for the biomarker positive subgroup using a reduced significance level, alpha 2, for example, 1%. Okay. And this test is significant. We measure the treatment efficacy for the biomarker positive subgroup. Otherwise, we make no assertion on treatment efficacy. Okay, again, fallback approaches are to respect the traditional overall test and prepare the subgroup analysis as a fallback option. Okay, as related approaches, we can consider parallel testing with co-primary hypothesis for the overall population and the biomarker positive subgroup. But that will have the same statistical properties when the traditional overall test is more respected. These approaches would be appropriate when there is less confidence in the biomarker. That is, there are weak credentials on the biomarkers. Okay. We can consider another approach, a hybrid of the fixed sequence one and fallback approaches. One such approach is proposed marker sequential test called MAST. Okay. In this design, we first test treatment efficacy in the biomarker positive subgroup using a reduced significance level, 2.2%. If this is significant, we test a treatment efficacy in the biomarker negative subgroup using a significance level, 2.5%, as in the fixed sequence 1 approach. If the first test is not significant, we may test treatment efficacy for the overall population at a reduced significance level, 0.3%. Okay. And last approaches, the treatment by biomarker interaction approaches. In these approaches, interaction test, preliminary interaction test of interaction of the treatment and the biomarker is performed to decide the whether to compare treatments overall or within biomarker subgroups. Here, the interaction test may be one-sided to detect larger treatment effects in the biomarker positive subgroup. Okay. To be more specific, we first test interaction one-sided using significance level, for example, 10%. If this test is significant, we proceed to test in the biomarker positive subgroup with a reduced significance level. And this test is significant. We measure treatment efficacy for the biomarker positive subgroup. Otherwise, we make no assertion on treatment efficacy. If the interaction test is not significant, we will test the treatment efficacy for the overall population with a reduced significance level. And if this test is significant, we measure treatment efficacy for the overall population. Otherwise, we will make no assertion on treatment efficacy. Okay. And all significance level must be specified to preserve the overall type 1 error rate based on the asymptotic distribution of the test statistic. We consider a test for treatment efficacy in biomarker subgroup using a standard usual log-rank test. And we consider a stratified log-rank test for testing a treatment efficacy in the overall populations. For the interaction test, we compare estimated treatment effects in terms of hazard ratio between the biomarker subgroup. We must take account of the correlation between the test for the overall population and that for the biomarker positive subgroup, which will be square root of the P plus, where P plus is the prevalence or proportion of biomarker positive in the study population. Also, correlation between interaction test and the test for treatment efficacy in the biomarker positive subgroup, which will be reduced to the square root of the 1 minus P plus when the event ratio between the biomarker subgroups are homogeneous. Okay. This is the example of the significance level. When allocating 60% of the total type 1 error rate, 2.5% to the overall test, that is, we use 1.5%, then we can specify the significance level for the biomarker positive subgroup using a 1.2%. Okay. Okay. So we now recall that all the approach can make either of the two kinds of assertion regarding treatment efficacy, one for overall population and the other for the biomarker positive subgroup. Based on this, we may interested in the three probability. That is, one is a probability for asserting treatment efficacy for the overall population, called P overall. And next, that for asserting treatment efficacy for biomarker positive subgroup, called P subgroup. And last one is the probability for asserting a treatment efficacy for either the overall population or the subgroup. This is the total power, but we call P success. This probability reflects the success of the treatment developers such as pharmaceutical companies. Based on these probabilities, we can argue that desirable assertion on treatment efficacy may depend on the underlying profile of treatment effects. When the new treatment has a constant effect of clinical importance, for example, hazard ratio is 0.7, 30% risk reduction by the new treatment in both biomarker subgroup. The assertion of treatment efficacy for the overall population would be more valid, but the assertion for the biomarker positive subgroup would deprive the remaining biomarker negative patient of the chance of receiving the effective treatment. So in this case, so we can argue that high P overall and low P subgroup would be desirable. On the other hand, for a case of qualitative interaction with a substantial treatment efficacy in the biomarker positive subgroup, but no treatment effects in the biomarker negative subgroup, the assertion of treatment efficacy for the biomarker positive subgroups would be more valid, but the assertion for the overall population would yield over-treatment for remaining biomarker negative patient using an ineffective, even toxic treatment. So for this case, we can argue that for high P subgroup and low P overall would be desirable. Okay. So however, for a case of quantitative interaction, where substantial treatment efficacy for the biomarker positive subgroup, but moderate to small effects in the biomarker negative subgroup, which is of two assertions should be considered to be valid, would be determined on a case-by-case basis, incorporating many factors such as prevalence of the biomarker positive and possible adverse reactions, and availability of the other treatment or choices and treatment costs and so But in this case, so we can argue that the high P success, high total power or P success would be another relevant criterion. Okay, well, I see. Thank you. So this slide compare the three probability for various number of events. So for constant effects, okay, where the high P overall and low P subgroup are relevant, the traditional approach without use of the biomarker, black curve, performs the best. And fallback and interaction approaches performed well, orange line and red line, with slightly reduced P overall. But the other approach provided smaller P overall. Okay, next. For the qualitative interaction, where the high P subgroup and low P overall will be desirable. So in this case, so fixed sequence 1 and the hybrid or master and interaction blue, purple, and red provided high P subgroup. But the other, fallback and fixed sequence 2 can be a problem. So because they provided very small P subgroup, while provide larger P overall. And for the last scenario, the qualitative interaction, the characteristic of each approach became clearer. But in terms of the total power or P success, all the approaches were comparable. Okay. Based on this argument, we are now propose criteria for sample size calculation and weak biomarker credentials, which is reasonable, like traditional clinical trials, to ensure that the total power is greater than high level, for example, 0.9, and the bias situation of the treatment effect profile, including a constant effect, qualitative interaction, and positive quantitative interactions. And then we need to consider additional requirement on the control of P overall and P subgroup. That is P overall greater than high value 0.8 and the P subgroup less than small value 0.2 and the constant effects. Also, P overall is less than small value 0.2 and P subgroup greater than 0.8 and the quantitative interaction. Okay. And this slide shows how each approach can meet the criteria. Generally, it is very difficult to meet the additional criteria on P overall and P subgroup. When looking at total number of events over 300, we can see only the master hybrid and interaction approaches can meet the criteria. As a summary, a fixed sequence, fallback, and traditional approaches are very difficult to meet the design criteria. On the other hand, the interaction and hybrid approaches can meet the criteria for reasonable number of events. So these two can be recommended in terms of the new design criteria and the weak biomarker credentials. Okay. So although we have so far concerned with power and sample size issues, I'd like to make some brief comments on the other issues related to the biomarkers-based design with a single predictive biomarker. First, the interim monitoring can be a problem because it easily compromises the integrity of the trial. In particular, the early stopping in either of the overall population or biomarker positive subgroup may preclude the testing in the other group afterward because of the using data that led to early stopping afterwards can be a problem. In the meanwhile, aggressive futility monitoring would be warranted to protect the biomarker negative patient who are more unlikely to benefit from the treatment. Another issue is estimation of treatment effects following repeated testing. For example, standard estimate of treatment efficacy in biomarker-positive subgroups may be biased following a non-significant treatment efficacy in the overall population in the fallback approaches, or significant interaction in the interaction approaches. So some bias correlation would be needed. Also, establishment of the criteria on clinical validity of the predictive biomarker would be needed, especially when asserting treatment efficacy for the biomarker-positive subgroup. These issues should be resolved. Okay, more extensively, there are many other types of statistical issues in biomarker-based design with multiple biomarker in the earlier phase 3 trials and also confirmatory phase 3 trials, including various types of adaptive designs. Okay. And a very interested audience may refer to the upcoming book. So this will be available. It's not currently available, but it will be available in early next year. Okay. It's a conclusion. So we are now in the middle of inference, shifting from the inference for mean characteristic in a broad population to the prediction for individual patients. So with a large amount of statistical issues, this is surely a never-ending challenge for biostatisticians. Okay, thank you very much.
Hi, Christine McLaren at University of California, Irvine. Thank you very much for a fascinating talk. I'm on a committee that reviews clinical trials for our cancer center, and one of the problems we have with these new types of designs is accrual. And I wondered if you had, because it typically it takes a lot longer to screen for individual subjects to find those that actually qualify with the biomarker. Could you give us any advice for our committees as to how to respond, in particular to the National Cancer Institute, who are telling us that we need to make sure that accrual happens in a timely fashion?
So yeah, thank you very much for your comment. So it's okay. It's really generally very difficult to conduct such all-comer design. It costs too much, and so I'm generally no idea. But the content I provided means that so we now do not use a traditional approach without use of biomarker based on the power and sample size I provided when we have some single biomarker with some biological evidence. So we can have some biomarker credential for such a biomarker. So yeah. Okay.
Thank you, Shigi. Our next speaker is Dr. Donna Ankerst. She is professor at the Technische University in Munich, Germany, and she also is research professor in biostatistics at the University of Texas in San Antonio. And she'll talk to us about risk calculators.
Thanks, Anjay, for organizing the session. Also, the conference organizers, I think they passed the first test, which is great food for lunch. Yes, so I'll talk about keeping risk calculators current. Let's see. Risk calculators have been in the news lately. In November, there was a big New York Times article about an apparent use of a risk calculator that was supposed to predict whether you had high risk of a cardiovascular event. It was based on the Framingham study, heart risk calculator. And the clinicians wanted to use this calculator, which is well known. It was built 20 years ago, to refer who would get statin use paid for by their insurance. Then a pair of prominent statisticians, epidemiologists at Harvard, did a validation study of the calculator on some contemporary populations and showed that this use of this calculator would greatly overestimate risk and refer many more people to statin use than needed it, because things have changed in the last 20 years. It's a more contemporary, healthy population. So it was interesting to see this if you work in the field of risk calculators, and also some of the things the clinicians were saying to the newspapers, such as, we don't have a really good idea of how these calculators are made, and we don't know what needs to be done. We need to look more into this for using. If you do work in this field, you'll see that almost nowadays there's a risk calculator for everything. And certainly for every type of cancer, diagnosis or prognosis, the NCI has started to collect these into one website, and they organize them by disease site. And you can even submit your own. It doesn't take a license or much to put something online. And my friend Mike Catan at the Cleveland Clinic, on his website at the Cleveland Clinic, has a risk calculator to make a risk calculator. So it's certainly a lot of potential out there, and there's no oversight. So one question that we want to ask is what needs to be done in this field. Well, if we look at the past, at the way that risk calculators have been established, and I'm talking about ones that are used online, they're sometimes used to refer patients to trials. They're certainly used by patients who are scanning the internet for information. It's been one calculator built on one general cohort, a very well-established cohort. And here I just have an example. You might use logistic regression to predict the onset of disease in the next 5 years, etc. And you would have some established risk factors that are collected in the clinic, available all the time, and use this to return a risk. Two examples are the Gale risk model, which was constructed back in 1989, FDA approved, based on a small number of predictors, risk factors, and then the one I'll talk about today, the prostate cancer prevention trial risk calculator, which is based on prostate-specific antigen. One of the leading markers is the serum marker, race, age, etc. The present, if you look at the literature, you look at the new risk models, they need to accommodate the new markers that have been discovered over the last 20 years, and this is ongoing. So what happens is you start to get these kind of compartmentalized models. It's sort of like how the Boeing Dreamliner was built in multiple places. Big disaster, but good analogy. And so you have some things collected in a base cohort that may be a very good cohort. It's a very good piece of land. But then there's been new markers, and typically these have been discovered and validated on much smaller case control studies because they're expensive, but they've been multiply proven. And you also have, of course, the genetic consortiums, which are really mobilizing, making data available on the internet, collecting large amounts of data as you need for the rare alleles. And this is all terrific, but these groups don't necessarily talk to each other, and they certainly don't measure the same risk factors. So it's specialized. One will specialize in one type of covariates without looking at the rest. There are methods now out there, both frequentist and Bayesian, for combining results from multiple studies. And there's Bayesian, I said this already. What needs to happen in the future, as this New York Times article showed, was that we need to get out of this static frame of mind. Tell me if I'm too loud, just raise your hands, because I'm very loud without a microphone. So what we need to do now, as evidenced by this article, is we need to think about not being static. The rest of the world is very dynamic. Things change all the time, updated. We need coefficients on our risk models that are going to change because risk changes, human behavior changes, technology changes, et cetera, as we'll see. So we need to attach little T's to this. Furthermore, as I'll show towards the end of the talk, if I get there, we need to start thinking about the fact that calculators can have very different risk behavior or prediction behavior across different cohorts. It's something I call the cohort effect, or that validation is a property not just of the risk tool, but of the cohort to which it's applied. So I think this is very understudied. And there's a lot of research into how to incorporate new markers. That's already done, but there's more limited on the effect of cohorts and what kind of bias is there. We'll see that in a few minutes. So the example I want to give you is the prostate cancer prevention trial, the PCBT-RC, I'll call it. It's available at this website. And it's a base calculator like the Framingham Heart Study that was built on a very good trial. In fact, one of the designers of the trial is sitting right here to my right, John Crowley. And I don't know how he got this in, but somehow he convinced the national government of the United States to biopsy every man regardless of PSA. And at the end of 7 years of follow-up. So it's a very unique trial in some regards, and it was actually a chemo prevention trial, but I'm just going to focus on the placebo. But if you can imagine a world where you're asked to undergo a biopsy regardless of your indicators and contribute to find out the true underlying rate of cancer, it's a very unique trial and it'll never be reproduced again. So we thought that a calculator built on 6,000 men from the placebo arm in 2006 would be bulletproof, as we say in Texas, not just foolproof. But we were soon wrong. Even a calculator in 2006 can be outdated. And so the calculator online is very easy to use. You just enter your basic risk factors. I have some examples here. And then we provide the code. I think transparency is a good thing, so there is the code there, so you can implement the model yourself. And we have published ways to incorporate some of the new markers. Some of those I'll talk about now, but not all. So the outcome of the calculator has been recently changed to have a more user-friendly interface, better for patients. They don't understand statistics so well. And so we getting into the era of personalized medicine. Instead of telling a patient they have a risk of cancer, we talk about a physician giving them anecdotal tales of their past experience. So the clinician for this study would say, if I had 100 men who looked just like you, these are the 100 smiley faces, and they had exactly your covariate values, your exact same risk going into the biopsy. So these are men trying to decide if they should get a biopsy for prostate cancer. Out of these 100 men that look just like you, in this case, 91 would have a biopsy that's negative. There would be 8 of my patients who had low-grade cancer, which is now subject to a different kind of treatment, and then 1% chance of high-grade, or 1 patient out of the 100. We give a little more information about the side effects to help a person make a decision about whether to undergo the biopsy, and that they can have an infection, can be deadly. And it happens, we put little thermometers in the random patients for which it happens. The clinician of this trial, the principal investigator of the PCBT, wanted to make a video, so I asked him to make a short 3-minute video describing the calculator. Well, it's 27 minutes long, but which is longer than he's ever talked to me. But anyway, you can get this direct from the horse's mouth, which is Ian Thompson explaining this calculator. So if you're out in a remote clinic somewhere, anywhere across the far ends of the earth, you can feel like you've had a personal consultation with Ian. And I do the help desk for this calculator, and I do get emails from patients all over the world. That's appropriate here for an international conference. It's one of the nice things about working on the internet. Incorporating new markers, I just want to briefly show some of the recent things we've done. So it's very easy in my mind to do this if you do a Bayesian, because it's very Bayesian, this idea of incorporating new information into existing information. So if you just apply Bayes' rule, if you let X be the PCBT risk factors that are commonly collected, this is prostate-specific antigen, digital rectal exam, sorry I don't have it defined here, family history, whether or not you've had a prior history, your race and your age, these are the standard things. And what you'd like is to update your calculator with some new markers. So the way you can do this is through Bayes' rule, which states that the posterior odds, given both the new and the old markers, equals the likelihood ratio times the prior odds. So what are the prior odds? They just depend on the established risk factors. They're the ratio of the probability of cancer given the X over the probability of no cancer. So if the odds are bigger than 1, you have a greater chance of having cancer for these risk factors X. You get this from the PCPT risk calculator. It has a simple form. It's analytic e to the beta prime x, if you use logistic regression, times this likelihood ratio, which is not the odds ratio. It's the probability of the new marker stratified by the existing covariates X and the cancer status. It's the ratio. So a likelihood value that's greater than 1 will indicate it's more likely you would see this value of the new markers in cancer cases than controls. And a value of 1 means it's just as likely. So these probability densities will depend on what kind of marker you have. If you have a discrete marker, continuous, you might specify a normal distribution. We'll see one brief example. When you multiply these two, you get the posterior odds, which then can be inverted to give the posterior risk. What's nice about this formula is that you can base your base calculator, such as from the Framingham Heart Study, on a very big cohort. That's your prior information. It can have low variance. And the update can be based on a case control study for the new markers, which is very efficient. Okay, so it can be much smaller because your total variability comes from both pieces. And and the reason this is nice, if you look at the genome consortiums and if you look at the new markers, let's say from the Early Detection Research Network of the United States, they're all doing case control studies. Unfortunately, they don't always collect the established risk factors. I wish they did, but sometimes that's just not feasible, especially for the genome consortium studies. So you can have a little bit of information coming from your new study and a lot from the old. This is an example of a recent analysis we did to incorporate single nucleotide polymorphisms. We found SNPs that were multiply validated by genome-wide association studies. They were multiply validated several times. We picked SNPs that were not in LD, not in linkage disequilibrium. And basically, the likelihood ratio, and these are studies, multiple studies contributing SNP likelihood ratios. So our likelihood ratio, our Y is a SNP. It takes on 3 values. Let's say there's a risk allele, which is big A. You have 2 copies of the risk allele, or 1 copy, which is A, little a, or no copies of the risk allele. So you get 3 sort of genotypes possible in the study, so you get a likelihood ratio or a likelihood ratio for each of the 3 genotypes with confidence bands from each of the studies. So I've put a line here at 1. So when the likelihood ratio crosses 1, when the confidence interval crosses 1, experiencing that genotype is just as common in cases or control. When it's bigger than 1, more commonly seen in cases. That's the red here. And so different studies, of course, have different sample sizes, and we like these forest plots. They can help us to see how the different studies contributed information on the same SNP. This SNP happened to have a lot. And at the end, we do a random effects multivariate meta-analysis, because each study contributes 3 correlated likelihood ratios. Lots of formulas to be had here, but I left them out just to have concepts. So at the end, we use this meta-analysis approach. And what's nice is that a lot of these genome-wide association studies publish these marginal frequencies of the SNPs in the cases and controls. So you can just go dig through lots of supplementary appendices and get your data out that way. Okay, it's not the odds ratios, it's the likelihood ratios, but these just come from the marginal frequencies. And so you end up having very large sample sizes over very many studies. Now, the shortcoming to calculating these likelihood ratios is that none of these genome-wide association papers are collecting prostate-specific antigen, digital rectal exam, the clinical covariates. So when you do your conditioning here, you don't have X. You're assuming you have the new marker, and you're not stratifying by the established. It's kind of like assuming you have no interaction in a model, basically, and you're forced to. When you do go to update your calculator, what I have here, the black line shows the estimated prostate cancer prevention trial risk calculator risk based on PSA, which is its strongest marker in the whole calculator. This is really the engine of prostate cancer risk models, PSA. And what I would show is that if a new patient came in, we have 30 SNPs that we looked at here individually, if a new patient came in with 0 risk alleles on each SNP, how would that, through Bayes' formula, modify the risk curve? And we see this by the multiple blue lines. There's 30 because there's 30 SNPs. If there was 1 risk allele, how would it change and if versus 2? So 2 will typically, we pick the risk allele to be that with higher frequency in cases. It will inflate the risk. I have some of the big moving SNPs here marked. Now, one problem is a lot of the SNPs with the highest effect sizes have the lowest prevalence, so they're not very common, they're very rare. And for a marker to be predictive, you need to have a high prevalence and you need to have a big effect. That's what you need. SNPs are expensive, so one value of the compartmentalized approach is that you can look at many different covariates coming from different sources. So SNPs are expensive. One can show they have little gain in area underneath the receiver operating characteristic points, which I'll define in a minute. Some people, like Ian Thompson, like detailed family history. This is just asking a questionnaire, what is your pedigree, what is your family history, down to some detail about first and second degree relatives, including relatives with breast cancer, because it's been shown that some other cancers can affect. Now, we've worked then with the Swedish Family Cancer Database. You can think of this as another factory. It's based in Heidelberg, which is not far from where I work. It is really the world's largest comprehensive family cancer registry. It includes the entire population of Sweden because everyone's on the national health insurance. And if you're on this insurance plan, you have to donate all your family data, so they know everything about everybody. And if you're born after 1931. So what we did was work very closely. Of course, what I found is that people don't like to give data to you. It's easier to get things validated by giving your calculator or your technology to them. Then you don't have to ask for any data. And so they ended up running the computations that I asked them to run on 55,168 prostate cancer cases versus 638,000 controls from independent families from the Swedish Family Cancer Database. And they computed the likelihood ratios, again, not stratified by the clinical risk factors, and they shipped them back to me, and we just update our risk calculator. And if you look at it, this again is the PCPT-RC risk if you did not use detailed family history versus PSA. This is what most people use. But if you would just take a minute to fill out a one-page questionnaire asking about some family relatives, as I indicate here, FDR means first-degree relative, SDR means second-degree relative, as well as their age of diagnosis, because that's important. You would get shifts this large. Now, of course, having lots of brothers with prostate cancer, et cetera, is very rare. So for a lot of people, it makes no difference. And the second thing I want to say is when you build a compartmentalized risk calculator like this, you don't have a validation set that has all the covariates. Okay, so that's the idea thing that you would have had in the first place. That's not feasible, and so it really needs validation. So that's why you put things online. We found in the PCBT risk calculator, when we put things online, we got lots of validations of new markers, because people are out there or after new publications, and they want to readily collect these data. So you can get it validated, and then it appears in a publication somewhere. Now, let's talk about the need for change. So there is a need to account for changes that occur over time within an institution, as well as differences in patient populations between institutions. And I think this is one of the most understudied parts of the field. Just to give our own example, the PCBT cohort, which the calculator was based, was collected in the late 1990s up through 2004. The protocol for that was a 6-core biopsy. So what does a 6-core biopsy mean? Well, it means they randomly take 6 samples. They stick a needle kind of randomly, 3 on each side of the prostate. It's very easy to miss cancer by this result, by this procedure. And so modern practice now, since then, has converted to the 12-core, taking 6 samples on each side, or even more. And there's a new kind of technology emerging that's going to be even better at finding the cancer instead of randomly shooting, called the MRI fusion biopsies. These are already being used in Germany at many centers. So it's been well documented that a higher number of cores increases the likelihood of detecting cancer as well as detecting high-grade cancer. So if you have a calculator that was based on a 6-core technology like we did, it's outdated basically. You have a fundamental crack in the foundation there. And so at the same time as we saw this, we started to look at, well, what's the differences across institutions? The PCBT was a fairly white, older population in the United States. What do things look like when you get to more rural parts of the US, more ethnically mixed, as well as when you get out to Europe? And this was headed by Andrew Vickers, and he started the Prostate Biopsy Collaborative Group. He just asked institutions across the world to donate data. A lot of them came from a famous European randomized study of screening for prostate cancer, which is the equivalent of the PCBT, but it didn't have a required end-of-study biopsy, so they didn't have John Crowley as one of the designers. And it also, however, used a 6-core biopsy technique, which is outdated. So what you have here is we had, at the end, 10 different centers, and these were really a mix of different geography places, if they were screening or cohorts where you only went there after you were referred by a doctor at a primary practice, etc. Some of them used 6-core biopsies, and some were more modern, using 10 to 12 cores. And the basic question we asked was, is there difference in risk across these cohorts? Okay, and since PSA, this marker, prostate-specific antigen, is the primary driver, every risk calculator behaves essentially the same as this marker. We just plotted the empirical risk as a smooth low S function against PSA. So there's no model involved here. If you just look at these curves, you can see a big difference in how risk associated non-parametrically or non-model based with PSA. Okay, and so there's some of them just begin at 3 because in most cases you only ever biopsy someone if their PSA is bigger than 3. You can't biopsy someone with a PSA less than 3 unless you were in the prostate cancer prevention trial. So we tried to explain these cohort differences with covariates. So that's the typical statistician's answer, is that, well, if you collected the right covariates, you would get this. We tried everything. First of all, there's not a lot of covariates collected, and certainly the ones that we did collect didn't explain, including, is it a screening versus a clinical referral? So thinking about it more with Andrew Vickers, we thought about, well, you know, it should be, we're in this era of big data, and data are flowing into the hospitals every night, and they're going into these electronic medical records, EMR. And so the data are there, and there's lots of prostate biopsies being performed everywhere, every day, just like mammograms for breast cancer. Why is no one collecting this data and just using it? In principle, if every hospital got on the ball, they could collect this data nightly and update a risk calculator, just as you would if you worked for a marketing firm and it was, you know, your bread and butter to make money and be the most current. So we thought, you know, we should get into this mode, basically. And so we decided to go back and look at this prostate biopsy collaborative group and think about, well, suppose we were building a model from scratch and we wanted to update it every year because I wanted to have a high enough sample size. If we had did this retrospectively in this cohort, how would I do it? Well, there's a few ways you can do it. One is you don't do it at all. You just use the online risk calculator, which is what we're telling people to do now, which could be wrong. The other would be you just use what's called a clean slate approach. You just, every year, you take all the data you have so far and build a new model from scratch. I work a lot with Ewout Steyerberg now, who wrote one of the big textbooks on this. You could do something simple called revision. It's a frequentist method. All you do is you would take an existing risk model, let's take the PCBT-RC, and let's take the linear predictor of it. Okay, it's got a nice spread out distribution as one potential covariate among all the other risk factors that could be there, and put that in your model. So that's like treating the PCBT-RC linear risk predictor as a new marker that's a combined marker. And you can still enter PSA separately in the model. But this thing is forced to be in there every time. There's a Bayesian way, which was very attractive to me, because that's how I was trained. You would just, every year, your posterior would become your prior for the next year. And you would do updating on parameters in a Bayesian way sequentially every year. And then because The computer scientists are always using random forest and saying how great it is for prediction, and it's used for Netflix challenges. We thought, well, let's try to use one of these robust ensemble learning methods that fits a series of random trees, just as the people who work for Netflix who are making money doing this do it. The data looked like this. We broke down the biopsies from each of our cohorts. We only had really good sample sizes in 7 cohorts. We broke it down by year. This is how many biopsies were done. And you can see that some cohorts occur later in time, etc. Some are very long. Durham is one of my favorite cohorts in North Carolina because my calculator performs the best on it. But they have a very large sample size, and they have about 50% African Americans, which is amazing. So the training sets that we decided to use in our little experiment here is we start with year 1 and we go forward. So if we look at Göteborg, we might start in 1995, and we build a model based on this, and we predict it the next year. And we calculate the AUC, and I'm just going to calculate a calibration statistic to show how well. I'll explain that in a minute. And then the next step would be we move up to 1996, and we use all data in the past to predict 1997. And we just keep going. So every year your training set gets bigger, but the validation set is always the next year. Okay, so that's how we do it. So you end up getting many validations serially over time. This is what the cancer rates look like every year. So the base prevalence of cancer every year is going to be one of the big drivers. That's what moving your intercept the most. And if we look at the cohorts already, they have an extreme amount of variation in their prevalences by year. So here I have years starting from 1993 to 2008. What we see is that Durham has a very high cancer rate, prostate cancer. So 50%, or just under 50% at the beginning, are diagnosed with prostate cancer. Now, remember, Durham is based in African-American part of the United States. These people only ever go in the clinic when it's severe because they have a social and cultural stigma against it in many cases. It's very hard to reach out to these people, and they need it the most. They're at high risk. And so they have a high risk compared to another cohort, let's say Göteborg in Sweden, which is very low. So the European rates are always lower than the American rates. And then you have everything sort of in between. Cleveland Clinic is somewhat similar to Durham in the regard that it's got a fairly high rate. So there's two of these cohorts are clinical referral cohorts. They have the highest rate. The rest are screening. They have somewhat lower rates over time. Okay, so now what this graph shows is a plot of area underneath the receiver operating characteristic curves over time by year in each cohort. So the AUC is a measure of discrimination, and I'm sorry I don't have the formula for it. It boils down to the probability that for a randomly selected case and control, the cancer case has a higher risk probability associated with your model. So you want a high AUC, and 100% would be the best, and 50% is the worst. 50% is no better than flipping a coin. So we have the 5 updating methods that I talked about, the static use of our calculators in black, and we have the revision in red and down to random forest in green. And what you first see is that not a lot of difference between these methods. As you'll see, the AUC is like a stone, it can't be budged. It's a very robust statistic. It's robust to everything. So the other thing that was surprising to me was these AUCs did not get better with time. Because remember, our training samples are increasing. They're getting bigger. You're getting more tailored every year. AUC is not going up. And there's a lot of variability. There can be really bad variability at some times. Let's look now not just at discrimination, which is a very rank-based crude measure, but at calibration, which shows how close are the actual risk to the true risk. And to just keep it simple, because we've looked at this every way, we use the Hosmer-Ledmesal calibration statistic, which just matches quantiles of people by the risk calculator versus the observed risk, and looks at observed minus expected over the standard error squared, summed up, over the deciles. 1 minute. Okay, good, because I just have one slide after this. And what we see, and so in this case, lower is better. Lower means you're more accurate. And what we see in this case is that the PCPT-RC, our static calculator, can be very bad. By the way, random forest is not on here because it was so poor it fell off the graph. And we see that some of the revision methods are much, much better here. They have lower. But sometimes you see a cohort is particularly strange, and so the revision to that cohort doesn't do well at all, and it was good to use our static. But overall, the static is performing much worse, as we see in these cohorts here. It's always above, so you should always revise and update your calculator. Here I just show that by the AUCs, I just show the average over the years plus standard error, so we can see black is the PCBT risk calculator. Higher AUCs are better, and what we see is that revision, the orange tends to win, but not much difference except for random forest. And when we go to calibration, where higher is worse, we see that the PCBT is really bad sometimes, so you wouldn't want to use it. Okay, so revision was our recommended. What we're doing now is we have a grant pending to start prospectively collecting all the covariates, because there's a lot of missing data, and designing risk calculators from a prospective viewpoint using electronic medical records, and that automatically update and for institution and global risk prediction. Thank you, everyone, and Florence in particular.
Oops, any questions? Somebody way up there. Right there.
Hi, this is Sumitra Mandrekar from Mayo Clinic. Excellent talk. In general, I just had a question for you and also for Mike. How would you, this one is excellent when you have, thousands of patients and you're able to develop this. But, we have a case which is a rare genotype, rare disease. We have only 200 patients that we have observed in 20 years. And here I have a physician that says, I need a risk calculator. We have to do a nomogram. We don't have external data sets for validation. How would we go about doing that? And on the same note, I had a question for Mike on rare genotypes. What is a nice way to design phase 2 trials to go to phase 3 when you have rare genotypes, right? Most often we end up doing like the NCI match initiative, which is all single-arm trials, and you probably don't have a proper control arm. You can't randomize so many patients. What are your thoughts on that?
I think in the interest of time, I'll just let Mike answer both questions.
Maybe we should wait until after the discussion, since those questions were pretty tough. So it has gone implied.
I think they're good questions.
Okay.
Yeah.
No, in terms of the clinical trials side, it is a big problem because, as you say, it becomes so rare. Then, am I not? Is it better? Okay, it's become so rare. It's difficult to do randomization if you want to do randomization. There's no good way around it. You just in the trial setting when there is randomization, the hope is the effect is so strong that you'll be able to detect it with relatively small sample sizes, but you can't do much more than that.
Ross Prentice, Seattle. So, hi, Donna.
Hi.
So if your goal is absolute risk prediction, the cohorts that you study are often specialized and have a lot of eligibility criteria and so on. How does that enter your risk calculators? And I guess secondly, your evaluations seem to be based on AUC and discrimination methods as opposed to evaluation of absolute risk, like you might use percent variation explained or some such criteria.
Right. So, regarding the specialized, that's what we're just hoping to get away from the problem by having these automatic methods that would update. Because when we try to collect covariates, which would say, have you been screened before? Is this your first PSA test ever, your first biopsy? These covariates didn't work very well. And so our hope is that by just dynamically updating a calculator, you don't have to worry about it. Now, the problem is not every institution can afford a calculator. And so in some sense, we're going to have to get around that. I'm not quite sure how we're going to do this, because I know some people are really opposed to posting different risks for the same disease, on one website. It's not clear. In terms of just using discrimination, yeah, that was the first thing we did, but then we added this Hosmer-Lemesau. And what we actually use in practice are calibration slopes or calibration curves, which match deciles. So you see which part for high risk, is it underestimating or low risk? The Hosmer-Lemesau just combines, these deciles, because we wanted one number. And there we did definitely show that using a static risk calculator is not going to work in every specialized setting. Yeah.
Thank you, Donna. Thank you all. Last but not least, we have a discussant today, Dr. John Crowley. John's been a colleague, mentor, and friend to all of us up here for many, many years. He was also the group statistician for SWOG for 20 plus years, and is the CEO and president of Cancer Research and Biostatistics, or CRAB. And he's going to summarize, discuss all of the things that have been said. So,
thank you very much, Antje. I'd like to congratulate all the speakers. As was mentioned, I have a certain personal connection with all of them, so it makes me proud to see their excellent work. They are somewhat disparate in content, as you saw, but I tried to find some prevailing themes to bring out and maybe emphasize with a few examples of my own. First from Mike. Mike actually taught me this, is don't be greedy. That's probably a Canadian trait, I would think. In this context, don't jump too quickly into a biomarker subset and bet all the money on that one subset. He's making that point even in phase 2 exploratory trials to carry forward more than just a subset into phase 3, barring knowledge that most of us think is not available. Secondly, be humble. Perhaps that's a Japanese stereotype. But going along with Shigeyuki's talk, one needs to consider the distinct possibility that assumptions that are made and given to you by the translational scientists are incorrect. And he looks at various ways to have it both ways, to look at the biomarker subset and the overall analysis. I was actually quite surprised that the interaction test approach worked so well. I think maybe part of the reason is that definition of probability of success, which I appreciate as a nice innovation. Finally, I guess for Donna, keep it simple. I was really pleased to see the most complicated of all approaches do the very worst in her validation exercises. I would add that risk calculation is risky and congratulate her for taking those risks. And throughout, I think all the talks, just like in real estate, is location, and Florence is an excellent one. With this kind of biomarker work, validation, validation, validation. So just to go back and illustrate some of the points with a little of my own experience. What are we looking for in this new age of putatively targeted agents? It's not just looking at does the agent have effect in all patients of a given tumor type, but does it have an effect in selected subsets, and if so, which subsets? Here's a panel of figures that relate to the first couple of talks. This is taken from a manuscript that Antje, Mike, and I published a while back in Clinical Cancer Research. So in each of these scenarios, the x-axis is a putative biomarker on an assumed continuous scale, and on the y-axis is some measure of treatment effect. So in scenario 1, the treatment is effective, but there's no relationship to biomarker whatsoever. In scenario 2, we've hit a cut point for the biomarker to the right of which there is a treatment effect, and to the left of which there is none. If I followed Shigeyuki carefully enough, I think he called this qualitative interaction. And this is the situation which translational researchers will tell you we are in. They'll tell you we know the target of an agent, we tell you we know how to measure that target and whether it's hit with a biomarker. They'll tell you they know the cut point. Don't believe it. Scenario 3 then is a case in which we actually missed the cut point, and so even to the left of the putative cut point there is some measure of effect. I believe Shigeyuki called this a quantitative interaction. Scenario 4 is really an interaction where there's a negative effect on one side of the cut point and a positive effect on the other. And scenario 5 is a case where there is a relationship between biomarker and treatment, but not biomarker and outcome, but not the treatment effect. So in the vernacular, that would be a prognostic, but not a predictive marker. Targeted agents, again, they're different from the old cytotoxic agents, which kill everything that divides, in that they are assumably more selective targets, but I'll show in a couple of illustrations along the lines of please be humble. We don't always know what we think we know, that there's often collateral damage even with the new targeted agents, and sometimes there's collateral benefit, unplanned or off-target effects. An illustration from SWOG that Mike and I have spent much of our careers with, S0023 in stage 3 non-small cell lung cancer. Patients are given chemo radiotherapy, and after that they're randomized, after consolidation therapy, randomized to one of the newer agents, gefitinib, an epidermal growth factor receptor inhibitor, or a placebo. These are the results of the trial as presented to the Data Monitoring Committee at interim analysis. And if you look closely, you see the experimental arm, gefitinib, the yellow curve, being actually worse than the placebo. A result which we don't yet understand to this day, and 14 years ago we did not collect samples. We don't know if we measured the biomarker or hit it in a subset, but this is just an illustration that there can be harm even with newer agents. On the other hand, this is the mother of all collateral benefits. An agent that Mike mentioned, imatinib, or Gleevec, was developed to go after a target that characterizes chronic myelogenous leukemia, or CML, which is the BCR-ABL translocation. And completely unplanned and unexpected, this agent also hits cells which express an antigen called c-KIT, which characterizes GI stromal tumors. And here you see 2 randomized doses of Gleevec, which were not very different, and superimposed on a curve of historical controls. A whopping big off-target, unplanned effect, a huge improvement with this targeted agent in a totally unexpected way. Here's a trial in SWOG, SO819, ongoing study in advanced non-small cell lung cancer. I use it to illustrate some of the points that Shigeyuki made and also the point I'm making about caution. This is a study in which patients are given some standard chemotherapy, carbo and Taxol. They're given an anti-angiogenic agent, bevacizumab, if they're eligible for that, and then randomized to plus or minus another EGFR inhibitor, cetuximab, a monoclonal antibody. The marker being measured is the epidermal growth factor receptor by fluorescent in situ hybridization. And the trial is what we call a hybrid, although it fits more into what Shigeyuki was talking about as a composite primary in his talk. And so we wanted to know, is it better in the FISH positive subset, and is it better overall? So we designed this hybrid trial, which in the FISH positive subset looks at a alternative hypothesis of a hazard ratio for progression-free survival of 1.33 with high power, and overall test of a hazard ratio lower of 1.2 in the overall population, the all-comer population. And you can see the alpha is split between those two subgroups. Here's a bit about sample size. we decided on a design that split the alpha between the FISH positive and the overall, and that called for 1,546 patients to be randomized, expecting about 618 to be marker positive. An all-comers design, which Yuki referred to, without looking at subsets, would be 1,400 patients, so slightly more than that, to cover the two bases in one trial. The marker positive design would be only about 600 patients. And the strategy design, which randomizes to a strategy of treatment based on the marker versus everyone getting treated, would take 2,400 patients. So here's the point I'm trying to make. Midway through the study, this is about a year ago, but the point is still illustrative. Accrued about 1,000 of the 1,500 patients. Specimens were available in 800 of those, adequate samples in just a little under 700. Of those, 273 were FISH positive, or 26% of the total sample, whereas the design criterion for FISH positivity, we expected about 40% positive. So just an illustration of the things that can go slightly wrong in the course of actually trying to do one of these trials. To get enough now FISH positive patients to achieve the objectives of the study, we're having to refigure the sample size requirements. I'll turn now to risk calculation for a few slides and illustrate some points with our experience. Being the stat center for a program in multiple myeloma based at the University of Arkansas in the US of A. So the treatment program that is used in multiple myeloma at this institution is aptly named total therapy, which is schematicized here, in which patients get induction chemotherapy, 2 cycles of high-dose therapy with autologous stem cell rescue, followed by consolidation and followed by maintenance, so a 4-year course of treatment. Again, aptly named total therapy. And here are the results of some successive trials over time from total therapy 1 in blue, total therapy 2, where we randomized to plus or minus thalidomide, minus thalidomide in red, plus thalidomide in green. So positive randomized trial. And finally, total therapy 3 in some shade of orange. And along with these heavily treated patients, we get gene expression profile from total therapy 2 on. So we have a high-dimensional possible biomarker, which of course raises all kinds of statistical challenges. Brief outline of the challenges and the ways to overcome them. Exploratory steps, some kind of data reduction. The current chip we're using from Affymetrix has 40,000 probes, so that's a lot of data. Statisticians, of course, uniquely aware of the multiple comparisons problem. In model building, stressing cross-validation and simplicity, interpretability, keep it simple. And again, validation, validation, validation. So we've developed a predictive score. It's actually a prognostic score, not a predictive one, using, turned out to be 70 of these gene expression probes, using log2 expression levels. And we developed an algorithm where we calculate a score using just the levels and not try to fit a model or weight them by any form of regression, Cox or otherwise. Then we dichotomize the score, try to find an optimal cut point, use some method of cross-validation to choose model size, trying to reduce the model size by cross-validation. And then with the final score, we find the optimal cut point, do that on a training set, and then look for external validation. So here's a distribution of the 70 gene score that we came up with as a continuous measure. And we see a hint there of 2 possible populations, low risk and high risk, in the distribution of those scores. At any rate, the red gives you the cut point that we chose to separate high-risk and low-risk patients. On the left is the result survival curves for low and high risk based on this biomarker, 70 gene score, and on the right is the validation set, which was the subsequent trial, TT3, the training set being TT2. So pretty good validation in this later trial in time. And I'll mention that this score has been validated in relapse patients in various European data sets. It seems to be quite robust. And one of the reasons I think is it's fairly simple. It doesn't try to adapt too much to the data, so it's more generalizable. We are, in fact, using the score. We're bold enough to use it to stratify patients. The score doesn't tell you exactly how to treat patients. I said it was prognostic, but with this kind of spread, it gave us enough indication that the patients with good risk probably ought to, maybe we can back off from that therapy a little bit. The patients with poor risk, maybe we should be a little bit more aggressive. So our new generation of trials, Total Therapy 4 and 5, one is for low risk and one is for high risk, with somewhat different treatment algorithm. And I'll just show our calculator, which we have been bold enough to do at one institution just for one set of investigators. On the top is overall survival, on the bottom panel is progression-free survival, and we have these simple toggles. So I'm showing you the high-risk patients for all the indicators, and they all are 0-1 indicators on the theme of keeping it simple. If we toggle all of them to good prognostic factors, here's the low-risk subgroup, and some measure of variability, which I'll leave undefined for the moment. And with that, we haven't tried to generalize this to other institutions. Probably when we do it next, we'll just update our current data with some kind of revision algorithm and not go to a random forest. But if we do have to generalize this beyond the data at hand, at least Donna's given us a roadmap for how to do so, and the courage to be bold. So with that, I'd like to thank all the speakers and thank the audience for their participation.